G'day, welcome to this video. I'm Jedynak. Today you are going to discover a fantastic assessment and treatment option for hamstring, lateral leg, as in peroneals, for the knee type of troubles, and specifically related to, locally, the fibula head, because we're going to do the fibula head mobilization. Now, this is a really important assessment and treatment technique to use because typically, podiatrists don't get taught this technique in their undergraduate training. It is a fantastic treatment option because when we look at closely at the fibula head, we've got to consider the anatomical structures that insert into the fibula head. Now I feel a little bit like Richard Attenborough, or is it David Attenborough? One of the Attenborough guys, as we look closely, and look what we're going to discover. But we're going to discover some fantastic treatment options here, both from an assessment and treatment perspective. We need to be, as practitioners, mindful of when we've got our patients who have hamstring troubles, also ITB or lateral leg problems, and peroneal problems. We've got to make sure we've covered all of the etiological factors. One of the crucial factors is when we have a patient where they're displaying a lot of subtalar joint pronation, and which is resulting with accompanying internal rotation of the leg. There is going to be some feedback from the mechanoreceptors going up to the brain, and essentially, poor old Scully, how's your brain going here? Oh, my brain is not going so well. He's a little bit lightheaded today, methinks. All right, so when we've got the internal rotation through the leg, that will send mechanoreceptor messages up to the brain, and the brain will then go, oh, hang on a second, if that internal rotation is excessive, we've got to do something about it. The way the brain does that is by sending messages to the muscles to switch on muscles to externally rotate. Now, how does that happen? Well, we've got the hip rotators, of course, that's going to be engaged, but the other muscle groups that we need to be thinking of are the hamstrings, because when the hamstrings and the ITB with the tensor fascia lata, when they contract, that will contribute to an external rotation moment. But those structures insert into the fibula head. And if that message or input from the brain is continuous or even excessive, because we've got internal rotation associated with subtalar pronation, then what happens is we get a lot of forces concentrated on the fibula head that results in the fibula head being pulled or displaced in a posterior direction. And if it becomes displaced and that's kept there for a chronic long-term perspective, we will get compensation of the fibula head in a posterior direction, which can affect the way the whole fibula functions and the muscles attached to the fibula, particularly the peroneal muscles and the hamstrings. So what this is going to do is, what we're going to do today is twofold. One, we're going to look at the position of the fibula head and what we can do to physically release it and free it up so that it can work into its optimum position. And the second thing is we're going to look at the neurological input. Now, what I mean by that, great quote from Dr. Rick Kring. He's got a PhD in neurophysiology. He's the director of neurophysiological research at the Cleveland Medical Center, which is only second in size and quality to the Mayo Clinic. So this guy knows a thing or two about neurophysiology. One of the comments that really stuck in my mind with the training that I did with him last year was we need to inhibit the inhibitors. Now, it's a little bit poetic there, but essentially what that means is if muscles are being inhibited because of the mechanoreceptor feedback loop up to the brain and the central nervous system and back down again, we need to, what that inhibition does is it switches off the activity to the muscles. So what that means is, particularly with the peroneals, we might find and observe in clinic situation that the muscles are weak. But it's not actually the muscles are weak, it's the inhibition of them to fire correctly and at the right time at the right intensity. So what this mobilization technique also does is inhibit the inhibitors, meaning switch off the inhibitors so that the muscles can fire and be strong, as strong as they can be. That's the goal with this technique. So we've got to go through some key steps. First step, we need to look at what are the clinical clues that would suggest mobilizing the fibular head would be of a benefit to our patients. So first clinical clue is we're going to look locally, and if there's tenderness around the knee or the fibular head itself, then that will be a clue. If your patient is describing problems related to the fibular head, as in hamstrings, we've also got ITB troubles or peroneal complaints, then that's going to be a clinical clue too. Next step will be the clinical tests. So what are the physical tests that we're going to do to determine whether we need to release or mobilize the fibular head? First clinical test is we're going to palpate. So using our fingertips and our fingers, our hands, we're going to check on the range of motion that may or may not be present with the fibular head. The fibular head is not a bone that's locked in position. It needs to glide and slide, as the whole fibula needs to be able to do as well. And what we're going to do is we're going to grab hold of the fibular head with our hands and mobilize, swing, and it's almost like an inverse pendulum. Normal motion of the fibular head will typically be posterior and superior, or posterior in the sagittal plane. And that's the motion we need to check for. The other clinical test that is worth you need to pay close attention to this, is hamstring weakness. And so this is not so much muscle, in fact, as I mentioned earlier about the inhibition of the hamstrings, that has nothing to do with the muscle strength of the hamstring group. So what happens is, I don't know if we're going to, here we go, Scully. Let's roll over. When we do the typical hamstring test and you ask your patient to resist, and we will check the muscle strength and how much resistance there is to that, this is a test you can do. It's almost like magic. And what you do is you compress the fibula against the tibia. So you literally compress, firm, hold for 2 or 3 seconds, and then retest the muscle strength. Now, when you get that compression, if there is a neurological interference, that compression will actually facilitate inhibition. It's almost a contradiction there. But what it does is it literally weakens the muscle. So you can press on here, check the muscle strength, and all of a sudden the hamstrings are weak. It's not the muscles that got weak, it's the neurological input. Then what you do is the opposite. You literally mobilize or almost distract the fibular head and check again what happens. If you notice a difference in the muscle strength as a result of the input on the fibular head, that is a clinical test and an indicator that there is neurological interference to the hamstring group as a result of the fibula. Does that make sense? There's a few steps involved with this, and I know we've got limited time together, but certainly in our workshops, we go through this in detail and demonstrate with the test, muscle strength, what happens with the different positions, whether it's compression, whether it's a mobilization, whether it's a high velocity release. These will have different effects on the actual neurological input and the result that happens to the mobilization and to the effect of the fibular head and the hamstrings, peroneal muscle groups. You can use any of the related muscle groups and test the impact that that has. Okay, so now, Scully, let's get you back into the position that typically would happen in a podiatry clinic, where we've got our patient in a supine or seated position. So now what we're going to do is the actual action of the fibular head mobilization. There are a number of steps here. First one is patient position, which is going to be supine here. You can certainly do this in a prone position as well, but I'll show you supine because that's probably the position that your patient is seated in front of you. The next is the practitioner, where you put your hands. So you need to grab hold of the fibular head. Now, this is a little bit, I've got a Ted's tip here for you. When we look at the fibular head, and we can grab hold of it with our fingers and thumb, now that's all well and good, but your patient has probably got a little more flesh and soft tissue structure than poor old Scully here. So the TEDS tip here is when you go to palpate or grab hold of the fibula head posteriorly, go further medial than you think. And the reason for that is invariably what happens is if you stay too posterior, it's very easy for your fingers to slide off and you don't have good purchase and control of the fibula head. So we're going to need to go posterior more than you think. Now, as you do that, TEDS tip number 2 is watch out for the peroneal nerve, because if you grab hold of the peroneal nerve and then apply pressure here, you'll know pretty quickly whether you've done that, because the patient, it'll be a reflex action. They'll either kick you, hit you, or swear at you. A lot of my patients do all three at the same time. They're very musical, very talented, and they've had a lot of experience and opportunity to do that. But moving right along. So put your fingers in further behind than you typically would imagine or anticipate. Then the action is to glide in a posterior and anterior direction. So it's a down 2, 3, back 2, 3. Oh, TEDS tip number 3. Might be number 4 now. Stabilize the leg, the medial leg, because if we didn't stabilize that, I noticed Scully's leg was rotating a bit here. Use your medial hand just to stabilize the leg. So I'll stabilize the tibia, and then the rate and the speed of the mobilization is down 2, 3, back 2, 3. You do 3 repetitions, posterior and anterior. If you don't get any noticeable improvement or movement in the range of movement that you've established, if it was limited from the outset, then repeat another 3 times. So it'll be 6 repetitions. Typically, that's as far as you need to go. Okay, when you're doing this, you need to pay attention to the quality of what you feel with the fibula head. When you have that classical excessive pronation pattern and the fibula head is displaced posteriorly, what you'll often notice is that all the tissues will adapt to that posterior displacement. And so sometimes it will be very easy for the fibula head to go posterior because that's its tendency. And there's a lot of resistance in getting the fibula to mobilize anteriorly. So that's a clue. Normally it would be symmetrical from its resting position, meaning there would be the same amount of posterior and anterior movement. If there is not symmetry with that, then what you would be indicated to do is to release the area of restriction. Where are those connective tissue restrictions? And then mobilize into that. So if it's resisting anterior movement, then you would put more force in applying in that anterior direction. There is certainly a number of key skills as to what you do with your fingers, the amount of pressure, how you stabilize, what the pre-intervention test and the post-intervention tests are about. And these are certainly the details that we go through in detail in our workshops to make sure you are fully equipped. But this is a test, just as an assessment, you can do in your clinic right now. Well, not right now because you're watching here, but with your very next patient. Or if you've got a skeleton, then you can practice, or practice even on your own fibula as well. Now that's an opportunity. Oh, geez, I probably should have shaved the legs or at least moisturize here. But then you can feel and palpate how far you need to go posteriorly and how far can you go. And you have to kind of work your way through the belly of the gastroc muscles so you get good hold of the fibula head. Because there's a lot of squishy moving bits. And then if you have your patients who have a little more flesh on them, then that becomes even more challenging. So certainly practice on your patients. Your next biomechanical assessment, this is not something that you do on a routine basis, then do that. Get used to the feel of those joints and what that it takes to really master manual control and manual therapeutic skills so that you can then do this fibula head mobilization. The important thing is do the clinical tests before, particularly the neurological tests, do the mobilization, and then repeat those clinical tests afterwards and notice what differences they've made to your intervention. From there, you'll be able to make some clinical decisions about, okay, well, their treatment, they need more mobilization, or they need more neurological input, or they need more training. Now, just on that, with the neurological input, if you find there's muscle weakness, but the nerves aren't switching those muscles on properly, strengthening them is going to be of limited benefit. You need to have the nerve inhibition released. You need to have those muscles fired and woken up at the right time, and then you can strengthen them and get some good therapeutic benefit from that strengthening. These are all important elements of being competent and comprehensive with your manual therapy and MSK treatment management. If you are interested in learning more about that, then go to YouTube, go to Google, type all the things in and see the plethora of information that's out there. You could spend the next 2 or 3 years focused solely, fully on working out how this works. Or you could spend 2 days with a live, intense, personalized workshop where we teach you everything you need to know and how to get the most effective results and the most effective treatments in the shortest time. Yes, there's an investment involved there, but it's going to save you a hell of a lot of time, money, effort, blood, sweat, and tears as well. I have no doubt about that, but I have such confidence in it. We have a 100% money-back guarantee with our workshop. So if that's of interest to you, we'll have the link on this video and on this post. And if you have any other questions, please let me know. I'll be doing my best to make sure I can help you help your patients more effectively. I reckon it's just about what we're going to be doing for now. So next visit, on your next visit, Scully, we are going to explore the talus. The talus is literally the universal joint that connects the leg and the foot and deals with ground reaction forces. So next up is going to be the talus. You won't want to miss that. That's coming to you live on Saturday. Saturday, yes, we work on weekends. So I hope that will be, look forward to your company then. Any questions, type them in the box. But until next time, surf with spirit, consult with care, and help more people today.